Good morning, Chairperson, moderators, and august audience. It's a real pleasure and privilege for me, and I thank the Scientific Committee of APCSI for giving the opportunity to talk about this topic, which is close to my heart. All of us as cardiologists are quite busy in our own respective areas, and in practice, we keep seeing different subsets of patients, either in the OPD or emergency room. And we follow certain protocols and pathways. The traditional risk score stratification, when we suspect a disease, and to suggest ischemia stress testing based on this traditional scoring system, and to suggest invasive angio if this ischemia testing is positive or suspicious. No doubt, in the past several decades, we have saved several lives. But is this all sufficient, or the methodology which we have been following, is this very precise and definitive diagnosis? Or are there alternative modes to improve our practice guidelines? CAD diagnosis in cath lab is an enigma to me even now, after team has done more than 125,000 angiograms in the past 25 years. But still we see a lot of patients who are apparently elderly, smokers, hypertensives, diabetics, and they come with some vague chest pain or breathlessness, and we feel that they will be having some disease, some critical disease, and they show like this normal. And many times this happens, and we do not know why some patients, this is a young patient, has got a calcium score of 3,685. And we do not know what is the vulnerability gene, polygenic theory or environmental theory, what is coming up is responsible for this. And another interesting patient, like totally normal, a lady, suddenly within 11 months, becoming 100% occluded with presenting with cardiogenic shock and LVF. So there are several issues, unresolved issues in the CAD management as we look at the accumulated evidence, especially in the past decade or so. Apart from the unpredictability and uncertainty of the disease, failure of the effective prophylaxis because of flaws in risk factor scoring system and inactionability of the ischemia stress testing and our inability to control or to reduce significantly the incidence of ACS and sudden cardiac death is a matter of real concern. And there is a real paradigm shift in the concept of acute coronary syndrome, ACS versus chronic coronary syndrome. And the very definition of coronary artery disease, the 50% is no more applicable, as we know that even for quite many years, though we know for 30, 40 years, we know that mild stenosis with vulnerable plaque can cause acute myocardial infarction. It is more common. And the fallacies of invasive angiogram, we know, and without FFR, IF4, even the experienced heart teams can go wrong in identifying the culprit vessel, or they change the strategy once they know, and they are blinded and unfolded. The blinding is unfolded for FFR and IFR from CABG to PCI, cultivation PCI, or vice versa. So in this context, with the flaws, the coronary artery calcium and CTCA come out in a big way, and CTCA seems to be one-stop shop. And the debates with regard to the accuracy and the radiation dose are now no longer tenable, and now it is accepted as almost as accurate as invasive angiogram. And the radiation dose, average radiation dose seems to be lower. So it's a time for us, cardiologists and radiation, the cath lab team, to protect ourselves from the hazards of radiation. And coming to the changes in the concept, we have changed from lesion focused to patient centered and vulnerable plaque patient, and from the coronary revascularization focus to early diagnosis and preventive cardiology. And we know that the burden of coronary artery disease is very high in India, especially in younger patients, and it's costs a fortune for a patient of 40-45-year-old. We see in our practice it costs a fortune for a patient of 40 to 45 years when he presents with acute coronary syndrome. Unfortunately, despite huge experience and scientific evidence, still the patients presenting to the ICCUs with acute coronary syndrome, significant number are grouped as low or intermediate risk patients. So attracting no statins or no active lifestyle advice, modification advice. And almost 50% of the patients with sudden cardiac death or acute MI do not have any symptoms. What is happening? What is happening is the primary care physicians treat these patients. Cardiologists enter the axis where the problem, and probably if we enter and if properly educated and if we have the alternative mode to identify the subclinical atherosclerosis, where in 30-40% vulnerable plaque ruptures and causes a complete 100% blood, probably some of these people could have been probably saved. And it is very surprising how a person who was in the gym yesterday suddenly dies early in the morning with chest discomfort of 10 minutes duration before reaching his cardiologist. This is not new to us. In fact, in 1984, Jim Fix, who was a famous marathoner, died, and he was found to have critical multivessel disease, and he was asymptomatic. So we know this quite many years ago, that mild stenosis is often the responsible lesion or the culprit lesion for acute coronary syndrome, as is proven in the recent trials in Scott Hart trial and Promise trial. So the subclinical CAD are the major risk factors, and all these, the improved targets for primary prevention and lifestyle changes and intervention, and intensive secondary prevention when there is acute coronary syndrome. The novel approaches to the personalized risk, the plaque quantification, perivascular fat attenuation, etc. The traditional risk score stratification misleads often, and ischemia stress testing as gold standard is questioned. Anatomical burden and plaque vulnerability is more important than the degree of stenosis. Eyeballing report of CAG without FFR, IFR leads to mismanagement, not uncommonly. And the CAC, CTCA, and CTFR seem to address all the above issues as one-stop shop. The wonderful study of the Framingham study, a longitudinal study with 4 generations, and subsequently a number of other risk score stratification, risk score systems failed to identify with precision, because these are all guessworks, and many people who do not need statins are put on statins, and people who require statins are considered as low or intermediate risk, and they are omitted from the statin eligibility. And this is how even patients who are present, majority of the patients with established CAD have 0 or 1, and the futility of the cardiac risk factors is known for almost 30 years, but little attention is paid, and still we have been leaning on this risk factor scoring system. But the CAC, the past 10 years, coronary artery calcium, is found to show a different scenario, clinical scenario. Either the patient has got 0 risk factors or 3 risk factors, it doesn't really matter. Patients who have calcium score of 400 definitely have an all-cause mortality, high all-cause mortality. So 0, 1, 2 risk. And not only this, even if the calcium score is less than 100, and if it is more than 0, even 1, 2 in young patients, it has to be taken with a pinch of salt, and we have to advise them strict lifestyle and if necessary statins based on the other risk factors and strict control of the risk factors. on risk factors has misled all of us, and many patients we can probably avoid polypulses. Now, coming to the CAC, we have several studies, of which one of which is MESA, which is a multi-ethnic study of atherosclerosis. And in asymptomatic patients, it has shown that there is a treatment opportunity. And when the calcium score is more than 300, the ACVDs events are more. And the age at which CAC testing should be done accordingly, it is arbitrary and probably any 35, 40, depending on the risk factors. And there are several studies, a landmark coronary artery calcium studies, which have shown that the mortality ACVD events are less, and especially when it is 0.16% ACVD events per year. And according to this, 50% of the current statin users do not need or not eligible. So in every study, it is superior and added to the risk factor stratification. If it is 0, reassure individualized statin aspirin, it is 1 to 100. More than 100, it is debatable. Aspirin is debatable nowadays, and the statin definitely yes. And aspirin, if it is 300 plus, probably many people recommend aspirin. So 0 is priceless, and which test can give you 15-year warranty. Now, with this, the ethnicity and the underlying comorbid conditions, the warranty is arbitrarily given. And ACC guidelines suggest for CTCA, the warranty is for 2 years. Now, CAC, if you see, after its introduction by this gentleman, by this great gentleman, there are several suggestions to improve upon the standard Egerton score. And this is how it is measured. And it integrates the risk exposure for traditional and non-risk factors, and probably there is a polygenic, a complex with environment factors which is responsible and which makes a person vulnerable or immune to development of atherosclerotic plaque and consequently and subsequently CAC. And now it has become a buzzword. So sometimes, this is a Trump effect. Sometimes you need celebrities to make an investigation popular. And this is non-gated. You don't need, gated ECG and complex algorithm, visual calcium, and in the non-gated ECGs and the incidental CAC and the CT, routine CT chest, and the breast cancer patients probably picks up some patients who have coronary artery disease. Similarly, de-risking is possible. And coming to the ischemia stress testing of the several gamut of tests, we recommend, we have been recommending ischemia stress test to pick up the patients who probably need invasive angio, and also to recommend line of therapy if the ischemia zone, if the myocardium at the jeopardy is high. However, ischemia, it is consistently shown that ischemia testing fails to diagnose AD, and whatever methodology you use, CMR, stress equals SPECT, obstructive and the non-obstructive CAD are similar when you do the invasive angiogram. So when you do the CT angiogram as a gatekeeper, 70% of the patients have significant CAD versus 50%, 55%. It's routine. So CTCA is preferable in those less than 65 years to rule out, and probably more than 65 years, it's age, then probably stress test. Still, nice guidelines say that for any patient, CTCA is preferable to ischemia testing, stress testing. Coming to the angiography, invasive angiogram, it shows that the radiation dose is not high, and the proportion of it saves time. The computed tomography saves time compared to invasive angiogram. And treadmill test shouldn't be a part of routine, the packages, cardiac packages, because it misleads more often than not. And calcium score and CT angiogram can predict chances of occurrence of heart attack in the next 15 years. So in most patients, the CTCA should be the initial test with stable chest pain patients. Ischemia stress tests are inappropriate in more than 50% of the patients, and a choose wisely concept has emerged from that. And we know the limitations of the coronary angiogram despite its high spatial and temporal resolution. Without it has its own pitfalls of our visual estimate. The most experienced our team, they had to change when they were unblinded, unfolding of the blind. Then the CT coronary angiogram is one-stop shop, and once this becomes widely available, probably it will be the most preferred test, and the primary physicians can utilize CTCA to refer the patients who seem to have borderline or significant disease to us. And what should we do? These are the varieties and types of lesions, normal to high risk. When it is significantly calcified, probably because of the blooming artifact, you may not be able to identify the stenosis severity. And the ulceration, the vulnerability can be picked up. And this is the RADS system, CAD RADS, from 0 to 5, depending to complete occlusion, normal to complete occlusion. One important aspect, normal cardiac CT has 100% negative predictive value. So the invasive angiography probably is the gold standard. We should advise, we should stop for diagnosis. And this is the Scott Hart study wherein it showed the adverse block on computed tomography identifies patients at increased risk of subsequent events. And ROMICAT 2 trial, presence of high-risk blocks and coronary CT in the emergency department increased likelihood of ACS, independent of the presence of significant stenosis. Iconic study again, high-risk block characteristics, independent of stenosis severity in coronary CTA. And then one very important aspect, CT versus invasive angiography in stable chest pain, the reason to choose should be, number one, major adverse cardiac events and are much less, and then major procedure-related complications, much less. So the radiation dose, the myths have gone, and almost a decade ago, significant fall in radiation dose has happened by iterative reconstruction, step and shoot, and prospective ECG gating, and the voltage and modulation from 120 to 80 kilowatts, and tube current. So the radiation dose, this is a study wherein the average radiation dose of CTCA is less than the average dose for invasive coronary angiogram. And then the comparatively, the accuracy of CTCA is over 97% in the ischemia trial, and ruling out any doubts with regard to the accuracy of CTCA. And the ongoing studies are there with regard to the segmental analysis. These are some of the studies wherein we have done with less than 2 millisieverts of CT scans for some of our thinner patients. And the radiation dose for CT coronary angiogram is 2 to 3 millisieverts. In CABG patients, it's slightly high. One important aspect all young cardiologists should remember is protection from the professional hazard, occupational hazards, and protect your backs. And this is my back. So, cervical spondylosis developed over years of cath lab work. Whatever the current data with regard to all the studies, clinical studies, now 2021 ACC, almost all society guidelines have changed and brought CTCA as class 1A recommendation for intermediate risk acute cardiac chest pain. And in stable cardiac chest pain also, it is class 1A for intermediate to high risk chest pain. The low risk chest pain, no further testing, probably the warranty period for normal CTCA is 2 years. And FFRCT is recommended once it is freely available. I think it will be a boon for all of us. And these are some of the first few angiograms wherein we did both CTCAs and invasive angiograms, more to come to convince our cardiologists that both are more or less similar in accuracy. We have an ICT 256 slice. And this is how the coronary artery calcium progressed in some of our patients since starting from 2011. Or the average rate of progression per year is 20 to 25%. Anything more faster supposed to be fulminant. And this is how some of the patients we show, and younger patients, 43-year-old, almost 700, and 44-year-old, and vague chest pain. This patient had got LCX 100%, and normally we wouldn't advise because he has no risk factors, and we would pass it off as the atypical chest pain. But CTCA picked up, and then we could start statins and the active lifestyle measures. This is another young doctor who had in 2017 and 2021. There is a progression of the disease, but the doctor remains asymptomatic, and his treadmill test is negative with good effort tolerance. We are still following the patient, and the RCA is quite dominant, so we're still following the patient. So the normal obese, this is another patient who came to OPD and is with vague with shortness of breath and vague chest pain. This showed RCA lesion, and we stented. Similarly, another patient, 41-year-old male with breathlessness, and CTCA showed with again CAC of 0, 95%, and we stented this patient. Another 74-year-old patient, and this is another interesting patient who had around 30-40% of stenosis in the LAD, and he was advised statins, which he stopped, as more than 50% of the patients were advised to stop statins. And unless you show them the clear-cut lesion and calcium, majority will be convinced to start. But this gentleman stopped despite being shown the calcium, and then this is what has happened. He developed acute myocardial infarction, and this is. And similarly, for the calcium score 0, again, long segment is in the proximal LAD. So there are several patients who have calcium score 0. This is common in Indian patients who develop, who are about a decade and a half present with ACS earlier compared to Caucasians. And these are some of the, this is my younger brother whose CTCA is normal around 50-year-old. This is another 58-year-old. There's no symptoms, absolutely came to visit me, and then this shows 95%. With, hazy lesion, he says about a month, for the past 1 month, he has got some vague, SOB on climbing upstairs, and we had to stent him. This is the post-PCI patient. And similarly, this is my chairman who underwent PCI about 11 years ago, and then his PCI was done about 3 years after the PCI. So this is how the post-stent CABG and the post-bypass patients we identified. It is easier in bypass patients, though slightly radiation dose is higher. In fact, in invasive CAG, it is much higher, and then sometimes you will not be able to pick up the grafts. And it is easy, and when you have CTCA to identify the culprit vessel. And this is another patient where you do PCT advice, and the patient develops symptoms after 3-4 years after the stenting, and especially only when it is more than 2.73 millimeters. The smallest stents we usually don't do, but because of the blooming artifact, in stented patients, even if there is haziness, probably you have to go for FFR if you suspect it to be the culprit lesion. That's some of the other stented lesions. So CTCA, a triple rule-out protocol, identified the pulmonary embolism in some of the patients, and ultimately in the pyramid of coronary artery disease, you have the role of CTCA primarily in the diagnosis, and number 2 in the functional assessment by myocardial perfusion, and the FFR CT, and also advising the treatment and the planning option of the execution.